Welcome back to the Deep Dive. Today we're going to get into something that, well, feels a bit fundamental. We're moving past just looking at drugs on a prescription pad and instead digging into the raw machinery of human survival. We're talking about the pharmacology of stress, of adaptation, and this is maybe the most important part of restraint.
Yeah.
We are analyzing the adrenal corticosteroids.
It's a system that I think almost everyone in medicine feels like they understand on the surface. You know, you've prescribed prednisone for a rash, or maybe you've taken a dose pack yourself for a bad back.
Right, it's common.
It's very common. But when you really peel back the layers, when you start looking at the molecular signaling, you realize this isn't just about inflammation. This is, at its core, the body's primary negotiation with a hostile environment.
That's the exact angle I wanted to take today. Because we get stuck thinking of these drugs as just anti-inflammatories.
We do.
But biologically, they're really survival signals.
Yeah.
They're designed to mobilize fuel when you're starving. They maintain blood pressure when you're bleeding. They shut down the immune system when it threatens to consume you from the inside out.
Precisely. And that incredible power comes with a massive, massive caveat, which is really the central tension of this whole topic.
Okay.
These are systems designed to pulse.
To pulse.
Yeah, to turn on, save your life, and then critically turn off immediately. The danger comes when we, as clinicians, intervene pharmacologically. We're often turning them on and just leaving them on.
Right.
And that completely changes the entire biological landscape of the patient.
So to guide us through this pretty complex landscape, we're doing what we always do. We're synthesizing two absolute heavyweights in the field.
The essentials.
We've got Katsung's Basic and Clinical Pharmacology, and specifically we're looking at their chapter on adrenal corticosteroids and adrenocortical antagonists. And this, for us, is providing the clinical scaffolding. Yeah. It's the what and the how of dosing and therapeutics.
It's the roadmap. And then we're pairing that with the chapter on ACTH, adrenal steroids, and the adrenal cortex from Goodman and Gilman's The Pharmacological Basis of Therapeutics.
The deep mechanics.
That's where we get the molecular reasoning. You know, Katsung gives you the dosage table that says dexamethasone is 25 times more potent than cortisol. Goodman and Gilman explains the electron density on the steroid ring that makes it 25 times more potent. It's the why.
And I think it's really important we add a disclaimer right here at the top. This conversation, this deep dive, it's an interpretive synthesis.
Yes.
It's a conceptual map we're building to help you navigate the territory. It is not a substitute for the text, and it is absolutely not a substitute for clinical judgment.
No, not at all.
If you are prepping for boards or you're treating patients, you still have to go back and actively read these chapters.
Think of this as the architectural tour before you study the blueprints. We're here to help you see the overall structure, so when you go to read, the details have a place to stick.
Okay, so with that in mind, let's establish our mission brief. What are the key pillars we need to build this mental model today?
We've really boiled it down to 5 core concepts. The first one is axis control. We need to reframe how we think about ACTH. It's not just a simple throttle for the adrenal gland. It's more like a structural gatekeeper.
A gatekeeper. Okay, I like that. What's number 2?
Second is what I call the specificity paradox. This is the one that always trips students up. You have cortisol, which regulates sugar, and aldosterone, which regulates salt.
And they look almost identical.
They're nearly the same molecule.
Yep.
So the question is, why doesn't getting stressed out cause you to instantly retain massive amounts of salt?
Right. Why don't we all blow up with high blood pressure every time we get scared?
Exactly. We're going to explain the elegant little molecular answer that solves that problem.
Okay.
Third is genomic influence. This explains that time lag you see with these drugs. You can push a huge dose of IV steroids, but they won't really work for hours. We need to understand why that is.
It's not like epinephrine where the effect is instantaneous.
Not at all. It's a slow burn, and it's by design. Fourth is what I just call respecting the drug. This is where we look at the structure-activity relationships. You know, why does adding a single fluorine atom or a double bond change the game completely?
The nuts and bolts of the pharmacology.
And finally, number 5, withdraw logic.
This feels like maybe the most important one for safety. The idea that the most dangerous part of steroid therapy isn't starting the drug.
It's stopping it.
It's stopping it.
Absolutely. We're going to talk about adrenal suppression, which is probably the most critical safety concept in this entire deep dive.
Okay, that's a fantastic roadmap. Let's unpack this. Let's start at the source, the factory. We always talk about the HPA axis, hypothalamus, pituitary, adrenal, but let's zoom in on the factory floor itself. The adrenal cortex.
I think that's the perfect place to start. The adrenal glands, they sit right on top of the kidneys, like little hats. And the cortex, which is the outer shell, is divided into three very distinct zones.
Yeah, the mnemonic.
The old mnemonic that medical students have used for decades. You just have to remember GFR.
Salt, sugar, sex.
Salt, sugar, sex. It just works.
I remember that one vividly. So let's break that down. G. What's the G?
The G is the outer layer, the zona glomerulosa. This zone produces mineralocorticoids, and the main one is aldosterone. That's our salt.
Okay.
But there's a really crucial nuance here that Goodman and Gilman does a great job of emphasizing. This outer layer it's largely autonomous.
Autonomous from what? Meaning it doesn't really report to the pituitary, to the boss.
Not primarily, no. While ACTH from the pituitary helps, keep the lights on and maintain the machinery, the zona glomerulosa is mainly listening to two other signals, angiotensin II and serum potassium levels.
So it's watching blood volume and electrolytes directly.
Directly, which makes perfect sense from an evolutionary standpoint, right? If you're bleeding out from an injury or if your potassium is dangerously high and threatening your heart.
You don't want to wait for a committee meeting in the brain to decide what to do.
Exactly. You need an immediate local salt-retaining response. It decouples that critical blood pressure management from the more systemic stress response, at least to some degree.
Okay, so that's the outer layer, the G. Then we move inward.
We move into the middle layer, the zona fasciculata.
Yes.
This is the main factory floor for the glucocorticoids, specifically cortisol. This is our sugar. And unlike the outer layer, this zone is completely, totally enslaved to the pituitary gland.
So this one does report to the boss.
100%. If ACTH isn't present, this layer doesn't just stop working. It goes dormant, it atrophies, it withers away.
The innermost layer.
That's the zona reticularis. The R, it produces androgens, like DHEA, and that's our sex component of the mnemonic. But honestly, for the purposes of this deep dive, the main action, the real drama, is in that middle layer, the zona fasciculata.
All right, so we've got the factory floor layout. Salt, sugar, sex. But a factory, it doesn't run without a manager. And in this case, the manager is ACTH, or corticotropin.
Right. And ACTH comes from the anterior pituitary. But this is where the biochemistry tells a really fascinating clinical story. ACTH isn't manufactured as some kind of standalone unit. It's not like the pituitary just 3D prints ACTH molecules on demand when it needs them.
It comes from something bigger.
It comes from a massive precursor protein. It's called POMC, pro-opiomelanocortin.
POMC. It sounds like a government agency or something.
It kind of does. Think of POMC as a large supply crate. It's a big protein that has multiple different tools packed together inside it. When the pituitary needs to send a signal to the adrenal gland, it takes this big POMC protein and it just chops it up with enzymes.
And when you chop it, you get ACTH.
Yeah.
But you must get other stuff too, right? Leftovers.
You get scraps. And one of the most important scraps that's produced alongside ACTH is something called MSH, melanocyte-stimulating hormone.
Melanocyte, as in skin pigment.
Melanin, exactly. And this little biochemical fact gives us this brilliant clinical connection that helps us distinguish between different types of adrenal failure.
Oh, this is interesting.
So imagine you have a patient with Addison's disease. This is primary adrenal failure. The adrenal gland itself is broken. Maybe it's been destroyed by an autoimmune process, maybe tuberculosis. Something has wrecked the factory.
So the adrenal gland isn't making cortisol, the factory is burned down.
Correct. But the pituitary gland, the boss, it doesn't know the factory burned down. All it knows is that cortisol production is at zero.
So it starts screaming.
It starts screaming. It ramps up production of POMC to churn out massive, massive amounts of ACTH, trying to whip that lazy adrenal gland back into shape.
It's trying to force production from a factory that doesn't exist anymore.
Right. But in doing so, because of that shared POMC precursor, the pituitary is also inadvertently dumping tons and tons of MSH into the bloodstream. The scrap material is just piling up everywhere.
And the result of all that MSH is?
Hyperpigmentation. The patient's skin turns a bronze color. Their gums can turn blue-black. It's a classic diagnostic sign. So if you see a patient who looks like they have this deep, unnatural tan, but they tell you they feel weak, nauseous, and their blood pressure's in the boots, you have to think Addison's disease.
And that's what distinguishes it from a pituitary problem.
Precisely. If the problem were secondary failure, meaning the pituitary itself was broken, it wouldn't be making POMC in the first place. So you'd have no ACTH, but you'd also have no MSH. That patient would be pale.
That is just such a cool example of how knowing the deep molecular biology actually explains what you see on a physical exam.
It's why this stuff matters.
So, okay, let's say the system is working. The ACTH gets to the adrenal gland. It arrives at the zona fasciculata. It knocks on the door. What happens next?
ACTH binds to a very specific receptor on the adrenal cortex called the MC2 receptor. This kicks off a G protein cascade, specifically the GSKMP pathway, which is a common theme in endocrinology.
Right.
But Goodman and Gilman makes a really important distinction here between what it calls the acute phase and the chronic phase of ACTH action.
Okay, so let's take those one at a time. What defines the acute phase?
The acute phase is happening in seconds to minutes. ACTH hits that receptor, and the immediate effect is not to manufacture a new hormone from scratch. That takes too long.
Okay.
Instead, it acts like a logistics manager. It just rushes the raw material to the assembly line.
And the raw material for all steroids is cholesterol, right?
Yes, cholesterol is the basic building block. There's a critical transport protein called STAR, that's STAR, for steroidogenic acute regulatory protein. ACTH essentially tells STAR to grab all the available cholesterol and rush it into the mitochondria where the enzymes are waiting to start converting it.
So the immediate response is purely logistical. It's a we need fuel now response.
Exactly. But then you have the chronic phase. If ACTH levels stay high for hours or days, the cell gets a different message. It starts to think, hey, this isn't just a momentary spike. This is the new normal. We need to expand our capacity.
So it literally builds a bigger factory.
It engages the genome. It starts transcribing DNA to build more of the enzymes, specifically the CYP enzymes, that perform the chemical conversions of cholesterol into cortisol. The adrenal gland itself actually increases in size. It gets more blood flow. It hypertrophies.
Which implies the inverse is also true, doesn't it? If you take away the ACTH.
The factory is decommissioned. The enzymes degrade. The cells atrophy, the gland physically shrinks. And this is such a crucial concept for later when we talk about withdrawal. You cannot just restart a factory instantly if it's been systematically torn down over months.
We will definitely get to that. But that mechanism, that physical atrophy versus hypertrophy, that is absolutely key.
It is. And just to round out this section, we should briefly mention the rhythm of this whole system. It's not a flat line during the day.
The circadian rhythm.
Yeah. Cortisol has a very distinct diurnal pattern. It peaks around 8 a.m., right when you wake up. It's the get-up-and-go signal. It mobilizes sugar to get you ready for the day.
And it drops off.
It drops throughout the day and hits its lowest point, its nadir, in the middle of the night while you're sleeping.
Which is why we usually tell patients on replacement therapy to take their steroids in the morning, right? We're trying to mimic that natural spike.
Exactly. You want to ride the natural wave, not fight against it. But, and this is a huge but severe stress, overrides everything.
The trump card.
It's the ultimate trump card. If you have severe trauma, overwhelming fear, hypoglycemia, sepsis, the body ignores the clock. It ignores the negative feedback loops that would normally shut things down. The brain just screams for cortisol, and the system delivers.
Okay, so the system has delivered. We've got cortisol floating in the blood. It gets to a target cell, a muscle cell, liver cell, whatever. How does it actually work? Because you mentioned earlier there's this time lag.
Right, and this brings us to section 2, the ghost in the machine. To understand the time lag, you have to understand the receptor dance.
Okay, and steroids are lipids, right? They're fats.
Yes, which means they are lipophilic, they love fat, they don't need a special channel or a transporter to get into a cell. They float right through the cell membrane like a ghost walking through a wall.
So the receptor isn't on the surface of the cell waiting to catch it like it is for insulin or epinephrine.
Exactly. It's hiding inside. It's in the cytoplasm, the glucocorticoid receptor, or GR for short. But it's not just sitting there idly waiting. It's actually being held in an inactive state. It's handcuffed.
Handcuffed by what?
By a complex of chaperone proteins, most famously the heat shock proteins, specifically HSP90. These proteins keep the receptor folded in a way that it can't function.
So it's inactive, it's restrained.
Correct. When the steroid molecule floats into the cell, it binds to a specific pocket on the receptor. And that binding acts like a key that unlocks the handcuffs.
The HSP90 falls off.
The HSP90 falls off, the receptor changes shape, and now it's active. It then finds another active receptor, and they pair up. They form a dimer. And this active pair now has a new destination. It marches into the nucleus.
Into the command center of the cell.
Right into the command center. And once it's inside the nucleus, it scans the DNA, looking for specific sequences. These are called GREs, glucocorticoid response elements.
And when it finds one,
it binds to the DNA and it starts changing gene transcription. It can either turn genes on or turn them off. It's telling the DNA to make new messenger RNA, which then goes out into the cell to be translated into new proteins.
And that whole process, finding the DNA, transcription, translation, making a new protein, that's what takes time.
It takes hours. That is the genomic effect. That is the time lag.
I want to pause on this because it is such a frequent point of confusion in acute care settings. Let's use the classic example. A kid comes into the ER with a severe asthma attack status asthmaticus.
Okay.
You give them IV methylprednisolone, a big dose of steroids.
And if you're standing there expecting it to work instantly, you are going to be very disappointed. For the first few hours, it will do almost nothing for the underlying biological mechanism of that attack, which is bronchoconstriction.
So why do we even give it?
We give it to prevent the next wave of inflammation. We give it to resolve the current inflammation over the next 12 to 24 hours. But for the immediate life-saving intervention, opening up that airway right now, you need epinephrine. You need albuterol.
Because those drugs work on surface receptors and have an effect in seconds.
Exactly. They work instantly. Steroids are the slow burn. They are the deep investment in calming the system down over the long haul.
That's such a critical clinical pearl. Don't expect instant miracles from a drug that has to talk to the genome.
Now, Katzung does note that there might be some very rapid non-genomic effects, maybe through some membrane-bound receptors, but the heavy lifting, the reason we prescribe these drugs for almost everything, is genomic. That's where the power lies.
All right, let's move to section 3, the specificity paradox. This is the part that, to me, feels like a really elegant detective story.
It really is a beautiful biological puzzle. So here's the setup. Chemically, as we said, cortisol and aldosterone are incredibly similar. They're both steroid rings with just these tiny little differences in their functional groups.
And we have way, way more cortisol in our blood than aldosterone.
Oh, orders of magnitude more. And here's the kicker. The mineralocorticoid receptor, the MR, the one in the kidney that is responsible for holding on to salt. It actually likes cortisol just as much as it likes aldosterone. Its binding affinity for both is very high.
So wait a minute. Let me get this straight. There's a massive flood of cortisol in our blood all the time.
Yep.
And the receptor in the kidney that retains salt is perfectly happy to bind to that cortisol.
Loves it.
So why aren't we all just walking around retaining massive amounts of salt and fluid all the time? Why aren't we all hypertensive and edematous just from our daily cortisol rhythm?
That is the paradox. Why doesn't our stress hormone constantly trigger our salt retention system? The answer is a bouncer.
A bouncer, like at a club.
Exactly like a bouncer at an exclusive club. There's an enzyme called 11-beta-hydroxysteroid dehydrogenase type 2. Let's just call it 11-beta-HSD2.
Okay, much easier.
This enzyme is found specifically in mineralocorticoid-sensitive tissues, like the distal tubule of the kidney. And it stands right next to the mineralocorticoid receptor. It's the gatekeeper.
And what does this bouncer do?
It acts like a sniper. As cortisol floats by trying to get to the receptor, the enzyme grabs it and chews it up. It converts cortisol, which is active, into cortisone, which is an inactive ketone. It essentially disarms the cortisol right at the door.
So cortisol tries to get into the club, the receptor, but the bouncer, 11-beta-HSD2, knocks it out before it can get in.
Exactly. But here is the brilliant part of the design. Aldosterone has a slightly different chemical structure. It has what's called a hemiacetal group at position 11. And that structure makes it immune to the enzyme. The bouncer can't touch it.
So aldosterone just waltzes right past the bouncer, completely untouched, and gets to the receptor.
That's it. It's incredibly elegant. The specificity isn't in the receptor itself, it's in the enzyme that's protecting the receptor.
It's a pre-receptor defense mechanism. That's amazing.
It is. But like any defense system, it can be breached, or it can be poisoned.
And this is where my favorite clinical tidbit comes in. This is where the licorice comes in.
Yes, we have to be specific here. We're talking about real licorice, from the licorice root, not the red candy that kids eat.
Right.
Real licorice contains a compound called glyceric acid, and this acid is a potent inhibitor of that bouncer enzyme, 11-beta-HSD2. It basically distracts the bouncer, ties him up.
So if you eat enough real licorice, you knock out the bouncer.
And suddenly, that massive flood of cortisol that's always in your blood does get to the kidney receptor, and it activates it just like aldosterone would.
So you get massive salt retention.
Massive salt retention, potassium loss, severe hypertension. It produces a clinical picture that looks exactly like mineralocorticoid excess, but if you were to measure the person's aldosterone levels, they'd actually be low because the body is trying to compensate for what it thinks is high aldosterone.
Wow. That is wild. Death by licorice.
It's a real clinical entity. And we also see the same mechanism fail in Cushing's syndrome. If you have a tumor that's pumping out astronomical amounts of cortisol, eventually you just overwhelm the enzyme. The bouncer can't keep up with the massive crowd trying to get in the door.
So the cortisol spills over.
It spills over into the mineralocorticoid system, and that's why you see fluid retention and hypertension as classic signs of Cushing's, even though it's a glucocorticoid problem.
This connects so perfectly to the next section, the drugs. Because if nature gave us these molecules with these specific effects, scientists were immediately going to start trying to hack them.
Of course. Once we understood the structure of the steroid nucleus, the game was on to try and design drugs that could improve on nature. And there are really three main design goals.
What were they?
1, make it stronger, increase the potency. 2, make it last longer, increase the duration and half-life. And 3, and this was the big one, separate the effects.
Get the good without the bad.
Exactly. Get all the amazing anti-inflammatory benefit of the glucocorticoids without the salt-retaining side effects of the mineralocorticoids.
So let's run through the roster of key players here. We start with the baseline, right? Hydrocortisone.
Hydrocortisone is easy. It is just pharmaceutical cortisol. It's the same molecule that your body makes. So by definition, it has a 1-to-1 ratio of glucocorticoid to mineralocorticoid effect, or, as we said, a 1-to-1 ratio of sugar to salt effect.
And so we use it mostly for replacement therapy and Addison's because it's a perfect mimic of nature.
Precisely. You're just giving back what's missing. But then we have the real workhorses, prednisone and prednisolone.
The bread and butter of steroid therapy.
Absolutely. So with these, chemists made a very subtle tweak. They added a double bond between carbon 1 and carbon 2 in the A ring of the steroid nucleus. That's it.
And what did that one little change do?
It changed the shape of the ring just enough to increase its glucocorticoid or anti-inflammatory potency by about 4 times, while at the same time slightly reducing its salt retention activity.
So it's a step in the right direction. More anti-inflammatory, less salt.
A huge step. And there's a little clinical catch with prednisone, isn't there?
Yes, the prodrug issue.
Right. Prednisone, as you take it in the pill, is technically inactive. It has a ketone group at position 11. Your liver has to convert that ketone into a hydroxyl group to turn it into the active form, which is prednisolone.
So if you have a patient with severe liver failure,
prednisone might not work very well for them because they can't perform that activation step. In that case, you might need to give them prednisolone directly to make sure they're getting the active drug.
That's a great point. Okay, so we step up from there to methylprednisol, and the name kind of gives it away.
Yeah, they just added a methyl group. That simple addition boosts the anti-inflammatory potency to about 5 times that of cortisol, and it has even less salt retention. This is often the IV drug we reach for in acute flares of things like MS or asthma.
And then we get to the heavy hitters.
Yeah.
Dexamethasone and betamethasone.
These are the nuclear options. This is where the chemists got really clever. They added a fluorine atom at the 9-alpha position of the steroid nucleus.
Why fluorine? What's so special about adding a halogen like that?
Fluorine is incredibly electronegative. It's a real electron hog. And by adding it there, it pulls electron density from across the molecule. This does 2 amazing things. It stabilizes the structure, so it's much harder for the body's enzymes to break it down.
To last longer.
Much longer, and it dramatically increases the drug's binding affinity for the glucocorticoid receptor.
So it hits harder and it lasts longer.
Way harder and way longer. Dexamethasone is about 25 to 30 times more potent as an anti-inflammatory than cortisol. Its biological half-life is over 36 hours. And crucially, it has basically 0 salt retention activity. It is a pure glucocorticoid.
Which is why we see dexamethasone used for things like brain edema from a tumor. You want the maximum possible anti-inflammatory effect with absolutely 0 extra fluid retention in the brain.
It's the perfect tool for that job. But then on the flip side, sometimes we actually want the salt retention.
Like in Addison's disease.
Exactly. The patient is losing salt, their blood pressure is low, so we have a drug designed for that specific purpose, fludrocortisone.
Which also has that fluorine atom, doesn't it?
It does, at the same 9-alpha position, but without the other tweaks that dexamethasone has, that fluorine atom instead makes it an incredibly potent mineralocorticoid. It is basically oral aldosterone. It is about 250 times more potent at retaining salt than cortisol is.
So we really have a whole toolkit, from pure replacement to pure anti-inflammatory to pure salt retention.
An amazing toolkit.
So we have the tools. Now, section 5, clinical integration. How do we actually put them to use?
Well, the first and most logical category is replacement therapy. as we've been discussing with Addison's disease.
And the goal here is simply to mimic what a healthy adrenal gland would do, right?
That's the entire goal. Act like a normal adrenal gland. And because we know the gland has that circadian rhythm, we try to match it. We often split the hydrocortisone dose.
How so?
We'll give 2/3 of the daily dose in the morning, right when they wake up, and the final 1/3 in the early afternoon, say around 2 or 3 p.m.
To mimic that natural curve of cortisol throughout the day.
Exactly. And then we add a small daily dose of fludrocortisone to replace the missing aldosterone and keep their salt and potassium in balance. But the most critical life or death thing for these patients to understand is stress dosing.
Explain what that is.
Remember, in a normal person, severe stress like an infection, an injury, surgery, it overrides the system and your adrenal glands pump out a huge surge of cortisol to help you cope.
Okay.
If your adrenal glands are dead, you can't do that. Your body has no reserve. So if an Addison's patient gets the flu or breaks their leg or needs even minor surgery, their body cannot mount a stress response. Their blood pressure will tank, their blood sugar will drop, and they will die of circulatory shock. It's called an adrenal crisis.
So they have to manually create the stress response with their pills.
Yes. They have to know to immediately double or even triple their daily dose of hydrocortisone. It is literally a survival mechanism. They have to be the brain for their own missing gland.
That's replacement. But the vast, vast majority of prescriptions we write for things like asthma, lupus, rheumatoid arthritis, organ transplants, that's not replacement therapy. That's suppression.
Correct. This is anti-inflammatory or immune suppression therapy. And the key concept that both Katsung and Goodman and Gilman stress here is that these drugs are palliative.
Now, palliative usually makes people think of end-of-life care.
In this pharmacological context, it means they treat the symptoms, not the underlying cause of the disease. If you have rheumatoid arthritis, steroids are incredible at stopping the joint inflammation and pain. They put out the fire.
But they don't fix the faulty wiring that caused the fire in the first place.
Perfectly said. As soon as you stop the drug, the fire often comes right back. So you're buying time or you're improving quality of life, but you are not curing the disease.
And how do they work so broadly?
They work at the genetic level to shut down the entire inflammatory cascade. They inhibit the production of cytokines like IL-1, IL-6, and TNF-alpha.
Yeah.
They suppress the function of T cells and B cells. They inhibit the COX-2 enzyme, blocking prostaglandin production. It's like a blanket suppression of the immune response.
Incredibly effective.
But the price for that effectiveness is high toxicity, as we'll see.
There is one very specific and fascinating use case that was highlighted in the reading. Fetal lung maturation.
This is one of the truly great success stories of modern obstetrics and neonatology. It turns out that cortisol is the natural signal that tells a fetus, hey, we're about to be born, it's time to get the lungs ready. It specifically stimulates the production of surfactant.
Surfactant being the substance that keeps the little air sacs in the lungs from collapsing.
Exactly. It reduces surface tension and allows the lungs to inflate with air. So if a mother is going into premature labor, the baby's lungs might not have made enough surfactant yet. They're not ready.
And they'll be born with respiratory distress syndrome.
Right, so we give the mother steroids before she delivers. But we don't just give her hydrocortisone, we give her betamethasone.
And why specifically betamethasone? There must be pharmacological reason.
There are two great reasons, rooted in everything we've just discussed. First, betamethasone doesn't bind very well to the proteins in the mother's blood. That means there's more free drug available to cross the placenta and get to the baby.
Okay, that makes sense.
Second, the placenta itself acts as a barrier. It has enzymes, specifically that 11-beta-HSD2 bouncer enzyme we talked about, that are there to chew up the mother's natural cortisol.
The placenta is trying to protect the fetus from the mother's own stress hormones.
Exactly. It's a protective shield. But betamethasone, with its unique chemical structure, is resistant to being broken down by that enzyme. So it slips right past the placental defense, it reaches the fetus intact, and it triggers those fetal lungs to mature. It has saved thousands upon thousands of babies from respiratory distress syndrome.
That's just a beautiful application of pharmacology. Okay, so we've talked about the good. Now we have to turn to the bad and the ugly. Section 6, the dark side.
The toxicity of long-term steroid use is profound and systemic. We call the clinical syndrome iatrogenic Cushing's. Iatrogenic just means doctor-caused. You are essentially giving the patient the same symptoms as someone with a cortisol-secreting tumor.
What did that actually look like in a person?
Well, first, it physically changes the shape of their body. You get this bizarre fat redistribution. Fat is taken from the arms and legs and moved to the trunk. You get the classic moon face, which is round, full cheeks. You get the buffalo hump, which is a fat pad on the back of the neck.
Yeah.
And you get increased visceral belly fat.
Those skinny arms and legs, but a round face and trunk.
Yes. It's because these drugs are catabolic on the periphery. They break down muscle and skin in the limbs to make sugar, but they're anabolic on central fat. It's a very strange combination.
You mentioned breaking down skin.
Oh, yes. The skin becomes thin, almost like tissue paper. It bruises incredibly easily, and you get these wide, purple, stray stretch marks across the abdomen and thighs because the underlying collagen is so weak that it just tears. And, of course, osteoporosis. It just leaches calcium from the bones.
And what about the internal chemical effects?
Hyperglycemia. We even call it steroid diabetes. Cortisol's main job is to raise blood sugar, and these drugs do it relentlessly. They tell the liver to make sugar, and they make the body's tissues resistant to insulin.
And the brain.
The CNS effects can be brutal. Insomnia is almost universal. Initially, there can be a feeling of euphoria or high energy, but with long-term use, it very commonly leads to severe depression, emotional lability, and even psychosis.
It sounds truly gruesome. But you said earlier there's a danger even greater than all these side effects of taking the drug. And that's the danger of stopping the drug.
Adrenal suppression. This is the one concept that every single person listening needs to understand inside and out. It's that important.
So walk us through that feedback loop one more time in this context.
Okay. You take a steroid pill, say 20 milligrams of prednisone every day. That pill gets absorbed, goes into your blood. Your brain, specifically your hypothalamus and pituitary, detects this high level of circulating steroid. And it thinks, oh, great, we've got plenty of cortisol on board. We can take a break.
So it stops making its own stimulating hormones, CRH and ACTH.
It completely shuts down production. It goes to sleep. And without ACTH constantly stimulating the adrenal factory, what happens to the factory?
It atrophies.
It atrophies. As we discussed in Section 1, the cells shrink, the enzymes degrade, the blood supply diminishes. The factory is essentially demolished.
Okay, so paint the picture. You've been on steroids for, say, 3 months for a lupus flare. Your pituitary is asleep, and your adrenal glands are withered away. And you decide to just stop taking the pills today. What happens tomorrow morning?
Tomorrow morning, you have zero cortisol. You're not taking the pill, and your own body has no ability to produce any.
And the result of that is?
Acute adrenal insufficiency. A full-blown adrenal crisis. Your blood pressure collapses. You start vomiting uncontrollably. Your electrolytes go into chaos. You can go into a coma and die of shock.
It's a true medical emergency.
It is one of the most frightening medical emergencies there is. And that is why we taper. We never, ever stop steroids abruptly after a prolonged course. We lower the dose slowly, methodically, over weeks or even months.
And we're not just tapering to prevent the disease from flaring back up.
No, that's part of it, but the main reason is physiological. We are buying time for the HPA axis to wake up from its slumber and for the adrenal gland to physically regrow its machinery.
Regrowing the factory. How long does that actually take?
Full recovery of the axis can take up to a year after a long course of suppressive steroids. A full year. Even after a patient is completely off the drug, their ability to mount a stress response might be blunted for months.
A year. That is incredibly sobering. And it really explains why clinicians are, or should be, so hesitant to prescribe long courses unless it's absolutely necessary.
And it's why any patient on long-term steroids needs to wear a medical alert bracelet. If they get into a car accident and are unconscious, the paramedics need to know that their adrenals are suppressed. They will need a huge stress dose of IV steroids immediately, or they simply will not survive the trauma.
Okay. Before we wrap up, let's briefly touch on the final section, Section 7, the inhibitors. We've talked about what to do when there's too little cortisol. What if the problem is too much cortisol, as in natural Cushing's disease from a tumor? How do we turn the system off?
We have a few interesting chemical wrenches we can throw into the gears of the steroid factory. A common one is ketoconazole.
The antifungal drug?
The very same. It's an antifungal, but at much higher doses, it has the side effect of inhibiting many of the CYP enzymes that are needed to synthesize steroids.
So a side effect that's been repurposed as a primary treatment.
Exactly. Then there's a drug called metarapone. This one is really interesting. It specifically blocks the very last step in cortisol synthesis, the conversion of a precursor into active cortisol. We actually use it more for diagnosis than treatment.
How so?
Well, if we give someone metarapone, it blocks that final step, so their cortisol levels should drop. In a healthy person, the pituitary should see that drop and respond by screaming louder, pumping out more ACTH. If we give the drug and the ACTH level doesn't rise, we know the pituitary itself is broken.
It's a way to test the integrity of the feedback loop.
Perfectly put. And finally, there's mifepristone.
Also known as RU486.
Yes, this one works differently. It's not a synthesis inhibitor, it's a receptor antagonist. It goes to the glucocorticoid receptor, sits in it, and just blocks it. It prevents cortisol from doing its job at the target tissue. It's a way to treat the symptoms of excess cortisol without actually stopping its production.
So we've covered the factory, the molecule, the drugs, the danger, and the inhibitors. As we pull back to the 30,000-foot view, what's the big picture here? What's the core lesson?
The big picture is that the adrenal corticosteroids are the pharmacology of adaptation. They are the chemical language our body uses to negotiate with a hostile and unpredictable environment.
But that negotiation always has a cost.
It always has a cost. That is the fundamental lesson of this whole chapter. You can borrow energy and resources from the future to survive today. That's what cortisol does. It breaks down muscle and bone for fuel. But if you never pay that debt back, the debt itself eventually destroys you.
That brings us perfectly to our final provocative thought for the listeners to take away.
I want to go back to that point that Katsung raises about epigenetics. We talked about the miracle of giving steroids to premature babies to save their lungs, and it works. It's an incredible life-saving intervention.
Right.
But Katsung mentions that this massive, unnatural exposure to glucocorticoids at a critical developmental window alters DNA methylation in the baby.
It's changing the programming of their genes?
It's changing the software. And there is emerging evidence to suggest that this early life exposure might program those babies for a higher risk of metabolic syndrome, obesity, or depression later in life. It forces us to ask a really tough question. Are we trading immediate survival for a lifetime of hidden biological consequences?
Are we hardwiring them for a high-stress metabolism that they can never really turn off?
It's a heavy thought. We are saving the hardware, the baby's body, but we might be rewriting the software in ways that we don't fully understand yet.
Wow.
It just reminds us that in medicine, every single intervention is a trade-off. There's no free lunch.
Well, on that profoundly important note, I think we have reached the end of our deep dive. This was fantastic.
If you really want to master this, my advice is to open Goodman and Gilman chapter 46 and just stare at the diagrams of the steroid synthesis pathways. Visualizing the factory floor really makes it stick. And then flip over to the dosage tables in Katsung chapter 39 to see how those small chemical changes translate into huge differences in clinical potency.
Knowledge is power, especially when that knowledge is what regulates your own blood pressure. Thank you for listening, and we will catch you on the next deep dive.
Stay curious.